This was a phase 2 study that was conducted through the Multiple Myeloma Research Consortium at 4 different sites. A total of 46 patients have been enrolled, and that's complete. 44 patients were evaluable before the cutoff for this abstract. And the study design is that all patients proceed with 12 cycles of quadruplet therapy, elotuzumab combined with carfilzomib, lenalidomide, dexamethasone. I'll call it Elo-KRd for short. And after 8 cycles, all patients underwent MRD testing by next-generation sequencing, and then again after 12 cycles. And the idea is that patients who were negative by MRD after both cycle 8 and cycle 12 could proceed with Elo-Rd alone, so dropping the carfilzomib. Patients who were positive after cycle 12, regardless of their cycle 8 result, would continue with 12 additional cycles of Elo-KRd, and then followed by Elo-Rd maintenance. Patients who were positive at cycle 8 but converted to negativity at cycle 12 would receive 6 additional cycles of Elo-KRd, so slightly shorter amount, and then Elo-Rd maintenance. And the primary endpoint for the study was really looking at stringent complete response and or MRD negativity rates after cycle 8, with a goal being greater than 50%. Now, some of the interesting things before I get to the results is that a high percentage of patients on this study actually had high-risk disease by FISH cytogenetics, which we defined as a translocation of 414, 1416, 1420, 1q gain or amplification, and or 17p deletion. So 57% were high risk, and 32% actually had 2 or more of these abnormalities, so-called double hit. About 34 of the 39 patients who had a baseline sample already sent for what we call clonality ID to enable MRD tracking by NGS had a trackable clone, so that's about 87%. And that's really what makes up these patient characteristics. I think the one other thing is to mention is we actually recruited about 20% minorities, which is, I think, an important piece of this. So when you think about the results from the study, what I think is relevant is, first of all, from the primary endpoint standpoint, 58% of patients thus far have achieved either a stringent complete response and or MRD negativity. And the reason that we chose this and or is because there are patients who may have IgG kappa paraprotein, where elotuzumab may actually register as a positive on the immunofixation. And so it's hard to distinguish between those who have a positive IFIX due to paraprotein versus the monoclonal antibody itself. But MRD negativity can serve as sort of a adjudicator of that. Now, it's important to note that none of the patients who were MRD negative at cycle 8 have progressed thus far. And that includes 6 patients who had high-risk cytogenetic abnormalities. So I think that's a really important piece. The other thing to make note of is the overall response rate was actually very high. It was 97%. And when we look at the combined patients who are in a complete response, at least a complete response, and MRD negativity, we're looking at 33%, with still more patients required to make it through the primary endpoint at cycle 8. So I think that's something really important to mention. One of the interesting things that we found here was really looking at the complementarity in MRD testing, both by next-generation sequencing, which was part of our primary endpoint, but also an exploratory endpoint of mass spectrometry. And we actually chose to use mass spectrometry here because it can actually help distinguish between the therapeutic monoclonal antibody and the paraprotein that may be seen. And what we found is that there was a fair amount of discordance between NGS and in the bone marrow and mass spectrometry as performed by liquid chromatography in the peripheral blood. There's actually about 35% discordance in total. But that discordance was split between those who had detectable disease by mass spec and undetectable disease by NGS, which was about 15.5%. And the other 19% were patients who had undetectable disease by mass spec, but detectable by next generation sequencing. And now we're seeing this in several other trials where Mass spectrometry and NGS actually have this complementarity to them. You're testing two different compartments and getting additional information from that. Survival data is a little immature. Right now, what we know is that patients who had standard risk disease, there's 100% 2-year PFS and overall survival. We should hope that that would be the case. And for the high-risk patients, the 2-year PFS was 79%, and the estimated overall survival at 2 years is 82% for high-risk patients. So we still need some additional long-term follow-up to really understand what is the impact of MRD negativity at these early time points, and as patients go through the protocol. One last thing I want to say is that I think this MRD adaptive design, which is becoming a little bit more common with in other trial designs, I think allows us to be able to de-escalate therapy as time goes on, and can provide us with good efficacy, treatments that have excellent efficacy really, while also reducing some of the toxicities and hopefully improving quality of life for patients.